two of you are here. So our topic for today is COPD, or chronic obstructive pulmonary disease. We already talked about asthma, and chronic obstructive pulmonary disease is going to be two diseases that we will be talking about, and that would be emphysema and chronic bronchitis. So when we talk about COPD, what is it? It's actually a disease. Both of them have airway limitation that is not fully reversible. And usually it is due to either a small airway that is going to be affected, or there's going to be destruction of lung tissue due to inflammatory processes. So this inflammation are usually caused by exposure to noxious gases or to particles. So when we are talking about COPD, it actually is a disease of the airways and the lungs. And as I said, it is characterized by progressive airflow limitation. And the thing is that it's not fully reversible. So that's the reason why a lot of physicians or even nurses think that COPD should just be limited to chronic bronchitis and emphysema, because in asthma, the changes are quite reversible. But in these two disease processes, the fact is that they're not fully reversible. And because of the chronic inflammation, they cause narrowing of the airways and decrease in the recoils of the lung. So the lung should expand, but it should recoil or get back to where it was. And this is going to be the problem as far as COPD is concerned. So when we talk about COPD, it basically or usually is going to be a disease that is present in smokers and those that are age above 40. And the prevalence increases with age. It is the third common cause of morbidity and mortality throughout the world. So let's take a look at the etiology. What are the causes of COPD? Well, the causes of COPD are not fully understood actually, but it is generally agreed that most important cause of chronic bronchitis and emphysema is going to be cigarette smoking, because COPD is going to be caused by prolonged exposures to harmful particles or gases. Now, other causes of COPD might be secondhand smoke or even third-hand smoke. And you might be wondering, what is third-hand smoke? Like, for example, people who go to a crowded area, they come home with their clothes stinking of cigarettes. That would be a third-hand smoke. There's also going to be, of course, environmental and occupational exposures. And there's also one actually deficiency that is going to cause destruction of lung parenchyma. And that's a deficiency of alpha-1 antitrypsin. And this is an autosomal dominant disorder. It results in the breakdown of lung tissue by an enzyme called elastase because of this deficiency. And of course, aging could also be factors in the development of COPD. So the two most common conditions of COPD are chronic bronchitis and emphysema. And most people diagnosed with COPD might have elements of both. So it's very rare to have just exclusive emphysema and the other one exclusive chronic bronchitis. There could be a combination of the two. Now, as I said, some argue that asthma should be classified as a chronic obstructive pulmonary disease, but others do not. And the reason for that is because in asthma, most of the changes are going to be reversible. So let's take a look at chronic bronchitis. What is chronic bronchitis? Well, this is a disease of the airways, and it is going to be characterized by the presence of a cough and sputum production. And this sputum production and cough has got to be over a period of at least 3 months in each 2 consecutive years. So, like, for example, in 2021, for 3 months, this person has the cough and, of course, the sputum production. And then in 2022, he or she had the same thing for at least 3 months. So it's got to be for 2 consecutive years. Now, this disease is usually referred to as blue bloaters, and we'll find out why it is usually described as a blue bloater, whereas emphysema are actually referred to as pink puffers. So there's a distinction between the two, and the reasons for that are going to be based on the amount of oxygen that's desaturated. And we'll talk more about that as far as the differences is concerned. And of course, for emphysema, infections usually causes them to have resurgence of the episode of bronchitis. And in emphysema, it is a little bit different. The pathophysiology is that there's going to be an abnormal distension of the air spaces. And this is going to be it will be localized to the acinar unit. So when I say acinar unit, I'm trying to, here you go. All right, so if this were our respiratory tract, our trachea, and then it goes into the right stem bronchus and so on, and it divides and divides and divides and divides into smaller areas, and finally you get into this unit called the alveoli. So these particular areas over here are what we call the acinar units. And this is exactly where the destruction is going to be. And the reason why there's going to be destruction is obviously because of the over-distension of the air spaces beyond the terminal bronchioles and destruction of the walls of the air spaces. So what happens in emphysema, actually, if I draw this and enlarge it, so if this were the alveoli are supposed to be something like this. So you have a lot of balloons that is going to inflate. Now, with the problem of emphysema, what usually happens is that these walls, these walls are going to be destroyed. So instead of having something like this, you're now going to have something like this, a bigger balloon. All right, so the question is a small balloon better than a big balloon? And the answer to that is the smaller balloon is much better because it has more surface area to exchange oxygen and carbon dioxide with the capillaries. So you're missing these areas when you have emphysema. And the other thing is, because it now is a big balloon, it loses its distensibility. Okay? So this is one pathology that is going to make us understand why in chronic bronchitis, it is referred to as blue bloaters, whereas in emphysema, they are pink puffers. So let's understand why that is. Okay, so you have a big balloon in emphysema. The capillary network surrounds it, and therefore there's still going to be good exchange between oxygen and carbon dioxide. So oxygen goes into the blood vessels, carbon dioxide goes out efficiently. So there's still gas exchange that is occurring. Contrast that now to what happens with chronic bronchitis. In chronic bronchitis, if these are the healthy alveoli, and this is the vascular bed, there's a lot of mucus that's going to be produced by the goblet cells. And so if you have a lot of mucus right here, what's going to happen is the patient breathes in oxygen, and it hardly can penetrate through all this mucus over here. And therefore, it cannot be absorbed right into the vascular bed efficiently. And carbon dioxide is going to have a similar difficulty in going out for the alveoli to expel it. And this results, therefore, in oxygen or hemoglobin that's not going to be oxygenated. So it results in cyanosis. So cyanosis is deoxygenated hemoglobin. And that gives us the blue hue or the color of patients with chronic bronchitis. So that's the difference between the two disease processes as far as their description is concerned. So one is blue bloater, and that's going to be chronic bronchitis. And in emphysema, this is going to be, of course, your pink puffers. Now, there's also types of emphysema. And as you could see in the illustration below, they could either be centrilobular or panlobular. But again, this is not important. But I just wanted to mention that this is going to be a destruction of the respiratory bronchiole and the alveolar duct and alveolus, and that would be panlobular. So meaning to say all of the smaller airways. Whereas in the others, it's just a little part of those particular structures that I have mentioned. All right, so again, let's look at the mechanism of injury and the pathologic process as far as emphysema is concerned. So again, I want to underscore that in emphysema, there's going to be destruction of the alveolar air sacs, which are the gas exchange surfaces of the lungs, and therefore it leads to obstructive physiology. So usually this begins with an irritant, and it causes an inflammatory response. Then the white blood cells in the forms of neutrophils and macrophages are recruited, and they release inflammatory mediators. So this is going to destroy the air sacs because of these inflammatory mediators. So you might be wondering, what are neutrophils and macrophages? Well, neutrophils are new or young WBCs, and macrophages are the resident defenders against an antigen or an infection. So they stay in tissues to defend it against invasion. What happens when these oxidants and this protease, being an enzyme, it leads to the destruction of the air sacs. And so when you destroy the air sacs, there's also going to be a destruction of elastin, and therefore there's going to be loss of elastic recoil. So this results in airway collapse when the patient exhales. So just imagine, for us, when we take in a deep breath, we breathe and the alveoli expands. And when we exhale, the alveoli will now deflate a little bit. It does not deflate all the way. And the reason why it does not deflate all the way is because of the presence of nitrogen in the atmosphere. So remember that we breathe 21% of oxygen, and 78% of what we breathe is actually nitrogen. And the function of nitrogen is very important in that it keeps this alveoli open. However, in patients with emphysema, because of the loss of elastin, so they've taken a deep breath and it cannot deflate properly, and therefore there's going to be air trapping that is going to occur, causing the overdistension of the alveoli. Right? So this also is going to lead to collapse of the lungs, and therefore what happens is that because of the lack of elastin, it's going to be much more difficult to again exhale because of the decrease in elastin. There's going to be a decrease in what is known as forced expiratory volume 1, which is if I ask you to blow through a spirometer and you blow, you usually will be blowing like this. But if I time it and only get the 1 second, because actually the strongest expiration is during the 1 second, this is going to be decreased in patients with emphysema. So you have observed them having difficulty blowing a candle on their birthday, for example, because in emphysema, there's going to be obstruction, and therefore there's going to be a decline in the forced expiratory volume, right? So there's going to be CO2 retention, and there's going to be an increase in the physiologic dead space. So what is dead space? A lot of people don't understand what dead space is, but supposing that this is my mouth and my nose, and this is my trachea and my bronchioles, bronchi, right and left, and then, of course, the bronchioles are going to be over here. All right. From this area all the way to this area, there is no gas exchange occurring. So when you breathe, oxygen is going to be lining over here. That's because it's not being absorbed. The oxygen that goes over here are the ones that are absorbed. So the non-absorbing areas is what we call the anatomical dead space. Okay? So in patients with emphysema, because there is destruction all the way up to here, you now have an increase in your dead space. There are more areas that are not exchanging oxygen and carbon dioxide. All right, so that is what anatomical dead space is concerned, or physiologic dead space, and that will be increased in these individuals. So what are the major pathologic changes in COPD? Well, there's going to be edema that's going to be present. The mucus secreting glands are going to enlarge, and the number of goblet cells will increase, and the airway walls are destroyed, including the septa. The septa are the ones that are going to be right over here, the ones that separate one alveoli to another. And there's going to be confluence or joining of adjacent alveoli. So if you have an alveoli over here and an alveoli over here, they eventually are going to join together. So they become larger, but therefore you lose some surface area where gas exchange can occur. And in addition to that, there's going to be thickening of the blood vessels. Now, when these areas enlarge, an area that enlarges is called a bulle. And sometimes the bulle may rupture, and then we call that a bleb. All right, so in patients with emphysema, they are predisposed to the development of a bulle, and when this ruptures, it's called a bleb. All right? Okay, so that's emphysema. Let's go to chronic bronchitis. So in chronic bronchitis, it affects the oxygen and carbon dioxide exchange because of the airway swelling and also because of the mucus production that narrows the airways and therefore reduces the flow of oxygen-rich air into the lung and carbon dioxide being able to get out of the lung. So when you have inflammation and swelling, it causes hypertrophy of the glands, which increases the goblet cells. And if you increase goblet cells, you're going to increase mucus production. And when you have increased mucus buildup, what's going to happen to the cilia? The cilia are the hairy-like structures right over here in the lungs that lines the respiratory airway. And their function is supposed to be to remove foreign matter as well as to expel excess mucus. Well, these cilia are now going to be paralyzed because of the inflammation. So mucus is no longer going to be secreted or excreted, and therefore it increases the individual to infection. So when you have this susceptibility to infection coupled by the swelling and mucus production, as I said earlier, again, I'm going to illustrate it if this is the respiratory unit. And the capillary network, let me change the ink over here. The capillaries are supposed to surround this area right over here. So these are the blood vessels, the capillaries. So the patient breathes in oxygen, but there's a lot of mucus over here. So that oxygen is going to have a very difficult time going into the vascular bed. And likewise, the carbon dioxide that is rich over in the venous blood circulation, which should go out over here, again finds the resistance from the mucus that is secreted, and therefore you're going to trap carbon dioxide. And that's the reason why there's going to be a lot of deoxygenated hemoglobin that causes the cyanosis in patients with chronic bronchitis. All right, so when you have this affecting the oxygen and carbon dioxide exchange, the pulmonary blood vessels also become distended, and you will develop right ventricular hypertrophy, and then eventually into a condition of heart failure. And this situation over here is described as cor pulmonale. Changes in the heart resulting from pulmonary disease. All right, so let's now go to the clinical presentation as far as COPD is concerned. COPD will obviously will present itself in adulthood and often during the winter months. So usually patients are going to have complaints of chronic and progressive dyspnea, as well as cough, wheezing, and sputum production. They might have also chest tightness, and because they are expending so much energy in breathing, they're going to have weight loss. So These are the characteristics of these chronic obstructive pulmonary disease. And you remember their alveoli are now going to be over-distended. They're going to be ballooned like this. So imagine that the chest is going to be full of this ballooned alveoli. What's going to happen then is it enlarges, and this is what we call barrel chest, right? So barrel chest occurs as a result of over-distension. So what's the definition of barrel chest? Now, when we have our chest like this and we measure our chest this way, so hypothetically, I'm going to say, let's say that this is 10 centimeters. If the patient is looking at the side, looking at it from the side, the chest circumference should be half of that, 5 centimeters. But in barrel chest, what's going to happen is you might have 10 centimeter here and 10 centimeter also in the anterior posterior diameter. This is what is known as the AP diameter, or the anterior posterior diameter. It becomes equal to the anterior diameter. So this is what is known as barrel chest. So what are some of the assessment and diagnostic findings in patients with COPD? The diagnosis and assessment of COPD must be done carefully, since the three main symptoms are common among these pulmonary disorders. And so what are the things that are going to be important? Well, the typical features. So the typical features include your cough, your progressive shortness of breath, sputum production, recurrence of respiratory tract infections, and then cyanosis, particularly in patients with bronchitis, fatigue, weight loss, wheezing, and of course, age 35 or 40, above 40 years of age. And then, of course, if they have these risk factors, and you can look at the risk factors, then this would strongly suggest the presence of COPD. And what we do is we do a spirometric evaluation in order to confirm the diagnosis. So the confirmation is by spirometry, and the measure two things: the forced expiratory volume in 1 second and the forced vital capacity. And if it is less than 70%, this is going to be a diagnosis confirming the presence of COPD. Okay, so in evaluating them, it's important to obtain history. As we said, that we need to look at the risk factors, pulmonary function studies, in particular, your spirometry readings. And this is a part of the pulmonary function test, ABGs, chest X-ray, CT scan. And because it could be caused by a deficiency of alpha-1 antitrypsin, then we would have to have a screening, a blood test, to determine if they have the deficiency itself. And then, of course, bronchogram, as well as a lung scan. ABGs are going to be very, very important for obvious reasons. Chest X-ray is also very important to exclude other diagnoses, as well as your CT scan, in order to make a differential diagnosis. So what is this DLCO test? Well, this is a test to assess for diffusion in the lungs. And usually they administer carbon monoxide to measure gas diffusion across the membrane. And because carbon dioxide, monoxide, I should say, combines with hemoglobin better than oxygen, then we're able to therefore look at how this is absorbed. And emphysema, that is the only obstructive disease that causes this diffusion dysfunction. And then bronchogram. This is like, let me see. This is a test to show the dilation of the bronchioles. So it's almost like an angiogram. So they try to determine how dilated the alveoli is on inspiration. And of course, lung scan is going to look at perfusion ventilation ratios. So these are some of the tests that are going to be used for these individuals. So what are some of the other tests that are going to be applicable? Well, CBC. Well, the reason why CBC is important is because of the fact that we might have an increase in our eosinophils, for example, or you could also have an infection, which would therefore explain why a patient is having a recurrence, particularly in chronic bronchitis. Your blood chemistries is going to be important, and also sputum culture, as well as cytologic examination. Cytology is going to rule out whether or not the patient has cancer, or maybe they might have an allergic disorder, and that is why cytology is very important. And then, of course, ECG, because there are going to be some changes associated with both emphysema and chronic bronchitis. And so one of them is going to be, when you see ECGs, you usually are going to see them like this. You would be able to identify the waveforms because they are tall, right? Now, in patients with emphysema, because you have, or even in bronchitis, because of the fact that you have barrel chest, so if this is the patient's chest, I'm not a very good illustrator. All right, so it's barrel chest, and this is now the heart. The heart is farther away from the chest wall. And so the ECGs are going to be very small. So if you see ECGs that are, the waveforms are going to be very small, it's because of the fact that the patient has emphysema. All right. And of course, ECG stress test, we are going to use this to determine the effectiveness of bronchodilator therapy, and also helps in developing or evaluating their exercise programs, if it is helping or not. Okay, let's go to our first poll. Okay, so let's discuss what the answer is to this question. All right, so a patient with COPD is on 4 liters of oxygen in the emergency room. Later, the client is unresponsive. Respirations is 8 per minute. What ABG values would the nurse expect to obtain? Well, before we go to the answer, I wanted to point out several things. The most dangerous time whenever you start oxygen to a patient is the first hour. So whenever you start oxygen to a patient, frequently check them because they might stop breathing. Okay, so let me repeat that again. If you start oxygen on a patient, you need to check them frequently during the first hour because oxygen can stop them from breathing again. And I'll explain that later in the next slides that follow. So that's one caveat. And the other thing is, now from that lesson, we have determined that the patient have now decreased their breathing to 8 per minute. So when you don't breathe, what do you accumulate? Well, you accumulate carbon dioxide, right? And you will have a decrease in your PO2, or the partial pressures of oxygen. So let's take a look at CO2. The normal CO2 is anywhere from 35 to 45. So over here, we see that the CO2 is 67. So this is high, okay? This is normal. This is normal. And this is low. So, but we're looking for this one because you remember, if you do not breathe enough, you will accumulate carbon dioxide. Likewise, when you don't breathe enough, your PO2 levels should decrease. And so anywhere from 90 to 95 is normal PO2. So this one is going to be decreased. This one is also going to be decreased. This is normal, and this is decreased. But this is what we're looking at. A PCO2 that is high and a PO2 that is low. Okay? So I hope that you understood that. And so the interpretation of this blood gas is that this is an acid, this is an acid, and of course this is normal. So this is an uncompensated respiratory acidosis. All right, this one is going to be acid. That's normal. This is acid. So this is going to be a metabolic acidosis. So that's A, that's B. And letter C, this is normal, normal, and normal. So that's a normal blood gas. And over here in letter D, this is alkalosis. This is alkalosis. And this is normal. So we have over here respiratory alkalosis. Is there any question about this blood gas or about this question? Okay. Okay, so let's discuss what's happening over here. All right. So one of the complications of COPD is going to be cor pulmonale. And cor pulmonale is going to be the combination of right ventricular hypertrophy plus pulmonary hypertension plus right atrial hypertrophy. So because of all this combination, you are going to now have right-sided heart failure. So we talked about right-sided heart failure yesterday. So remember that because the heart is right atrium, right ventricle, pulmonary artery, and then, of course, left atrium, and then left ventricle, right? So the failure is going to be here. And the reason why there's failure is mainly because of destruction of your lung parenchyma. So your blood vessels are destroyed in the lungs, causing pulmonary hypertension. So this would cause right-sided heart failure, not left-sided heart failure. Okay? So the correct answer here then is letter B. So what is polycythemia? Polycythemia is a complication of COPD, but this refers to the increase in the number of red blood cells. So why is there an increase of red blood cells in patients who have chronic lung disease? So let's take a look at the reason why. So what is the body's stimuli for producing red blood cells? Whenever there is a decrease in oxygen, the kidney is going to sense this, and it's going to secrete an enzyme called erythropoietin. And this erythropoietin is now going to increase or stimulate the bone marrow to produce more red blood cells. So every 3 months, if you remember, the red blood cells die off. And so basically, there's going to be a decrease in oxygen because you now have lost a red blood cell. And therefore, erythropoietin is going to be released. The bone marrow is bombarded, and now you increase your RBC. Now, if you have chronic hypoxemia, you therefore are going to have an increase in RBC. Okay? So this would give your reddish, ruddy color to individuals who have emphysema, and even sometimes in patients with bronchitis, because as you know, they can crisscross as far as the symptoms are concerned. Okay? So that is polycythemia. Left ventricular failure is usually not associated with lung disease. It's going to be more on right heart failure. And then, of course, in acidosis, this could be a complication also of COPD. But the question was asking, why is it that the patient gained 5 pounds? The reason why he gained 5 pounds is because he developed cor pulmonale, which leads to right-sided heart failure. Okay? All right, let's go to another one. Okay, so let's discuss. The answer to this one is letter B. All right, so let me explain and then I will come back to this question again. What is the reason we breathe? Okay, so why do we breathe? The stimuli for breathing is going to be an increase in CO2. So when the brain detects that we have a lot of carbon dioxide, it's going to stimulate respirations or breathing. So this is our drive to breathe normally, is the increase in carbon dioxide. However, in patients with chronic obstructive pulmonary disease, they are going to have chronically increase in carbon dioxide, and the brain now switches to another stimulation because the brain is now confused, and this doesn't become the stimuli to breathe anymore. And the stimuli to breathe becomes the lack of oxygen, called hypoxic drive. Okay, so the need for oxygen. So remember again that we breathe because we need to excrete carbon dioxide. That's how the brain stimulates us to breathe. But because these patients are chronically having increases of carbon dioxide, the brain switches now to another form of stimulation. And this is going to be a decrease in the oxygen levels in arterial blood. This is sensed by the peripheral chemoreceptors or special receptors that detects oxygen content, and they now command the patient to breathe. So that is the reason why when we have patients with COPD, we're very mindful of giving oxygen to them. Because let's say that I am having this hypoxic drive because I have COPD, but now I give you oxygen. That means to say that you will be satisfied, and therefore you will no longer have the need to breathe. That is the reason why we are very cautious in the amount of oxygen that we give to patients who have chronic lung disease. Okay, so that is the reason why the answer over here is a PO2 level of 50 millimeters of mercury, because you remember that in patients with COPD, their drive to breathe is what is known as hypoxic drive, or the need to obtain oxygen. Okay. So I hope that I explained that very well, adequately. So now let's go to the management and interventions of patients with COPD. What is the primary goal of treatment? Well, we want to control their symptoms as well as to improve their quality of life. And of course, this would include your smoking cessation, and annual influenza vaccination is recommended in all patients with COPD. But in addition to that, let's deal with the drugs that are going to be useful in these patients. And so it leads us now to the discussion of bronchodilators that are used in the treatment of COPD. Okay, so as a review, beta agonists are drugs that increases the reception of beta stimulation into the lungs. And so let's start with the sympathetic nervous system. So the sympathetic nervous system right over here and the parasympathetic nervous system right over here will have an important bearing in the treatment of patients with pulmonary disease. The sympathetic nervous system actually is going to secrete epinephrine or norepinephrine, and this is a hormone that comes from the adrenal gland. So the epinephrine is going to exert its effect by entering into special doors, okay? And there are two doors that epinephrine can go through. They're called alpha, and the other receptors are called beta receptors. So alpha receptors are going to be abundant in blood vessels, and so it would affect blood pressure by causing vasoconstriction. So we're not interested in this effect, but what we're interested in is right over here on the beta effect. So if adrenaline or epinephrine enters into beta receptors, there are two types of beta receptors, beta 1 and beta 2. And beta 1 is abundant in the heart. Remember, we have one heart. And beta 2, we have two lungs. So it's abundant in the lungs. And what is its main effect if it enters into the lungs? It causes bronchodilation. All right. So when we are treating patients, then we are going to have drugs that improves or facilitates the entry of epinephrine into beta 2 receptors. And so there are two classifications of beta 2 agonists. One is what's called SABA. SABAs act in less than 5 minutes, but they only last for a very short period of time. They dissipate within 4 hours. So LABAs, or long-acting beta agonists, act more than 5 minutes, and then it could last up to 12 hours. So if I was asking you what would be the PRN medication to use, is it would be SABA or LABA? What would be the rescue medications to use? Is it SABA or LABA?
SABA.
SABA, because it's short acting. You remember, it works in less than 5 minutes, but you would have to take it much more frequently. That's why it's called it's a PRN medication or a rescue medication. It is not going to prevent future attacks. But beta 2, LABAs of the beta 2 are going to prevent attacks. So they're preventive or prophylactic treatments. Okay, so let's take a look at the most common SABA, so the short-acting ones. This is albuterol, which is also called salbutamol. And the trade names are ProAir, Proventil, and Ventolin. Those are the common trade names for albuterol. And they could also include metoprolol as well as levalbuterol. The long-acting ones are salmeterol. Again, remember that this is salmeterol. And in the alphabet, B comes before M. And so the B is the short-acting. The M, salmeterol, is going to be the long-acting. Favorite of Nclex, because they want to know whether or not you know the difference between salbutamol and salmeterol. Okay, so salbutamol is going to be short-acting beta agonist. Salmeterol is going to be a long-acting beta agonist. So please remember that. And the most common that we use the trade is Ceravent Discus. And you could also have formoterol, indacterol, allopurinol. All these medications, by the way, that are beta agonists, all end in the suffix terol or tylenol. So it is easy to identify them because now they have the suffix terol or tylenol. Okay, let's go also to the parasympathetic nervous system. The parasympathetic nervous system exerts the effect through another hormone, and this hormone is what is known as acetylcholine. And that is why this particular branch of the autonomic nervous system is called the cholinergic system. All right, so what are the actions of acetylcholine? Acetylcholine has two receptors. So one receptor is what is known as nicotinic receptors. These are primarily in the brain and the nervous system. And the other kinds of receptors are going to be your muscarinic receptors. And muscarinic receptors are going to be abundant in the lungs, and their major effect on the lungs is bronchoconstriction. So this is now the opposite of the sympathetic nervous system. What we want to do is to block the effect of the muscarinic receptors. So if we block muscarinic receptors, we will never have bronchoconstriction. Okay? So for the beta, you want agonists. For the cholinergic, you want anticholinergic, or it's also called antimuscarinic. And it's easy because they end with tropium. Okay? So these are medications that are going to end with tropium. So these are the examples of your antimuscarinics, your ipratropium or Atrovent, your tiotropium, and the newer ones are not going to be tropium, but they're not used very frequently. So these two drugs, ipratropium or Atrovent and tiotropium or Spiriva, are the two most common ones. So remember the tropium that is going to be the suffix of these drugs. Okay, so ipratropium is a short-acting antimuscarinic agent or anticholinergic. This has been shown to be very good in managing patients with COPD, actually compared to beta-2 agonists. So sometimes, because beta agonists are going to be good and your anticholinergics are going to be very good, we combine the two. And so you might have a combination of these drugs that are going to be both ipratropium, short-acting beta agonists, and short-acting antimuscarinics, also called SAMAs. So if you have SAMA or LAMA, it's the same thing as SABA and LAMA. So SABA is short-acting beta agonist, short-acting antimuscarinic. Oops.
Okay, because I was about to ask you if there was a long-acting or short for the
There is. Yes, there is. Tiotropium, for example, is going to be a long-acting one. This is usually given on a daily basis. So this one is short-acting SAMA, short-acting muscarinic agent, and this one is LAMA. It's a long-acting anti-muscarinic agent. Okay, the others, aclidinium, all the way down are all LAMAs. They're long-acting anti-muscarinics. So there's only one short-acting anti-muscarinic agent, and that is Atrovent or ipratropium. Okay, so other than bronchodilators, so there are two kinds of bronchodilators. Remember, the beta agonists. So beta agonists are short-acting and long-acting. So they all end with what? You remember what they end with? T-role. Okay?
Yes.
And the anti-muscarinic, which are all going to end with what? Tropium. So remember that. Tropium, and the other one is going to be T-role. Okay. So are there other drugs other than bronchodilators? Well, obviously we do. And we also have other drugs that are not going to be delivered by the rest into the respiratory tract. We could have medications that are going to be oral medications. So one of those is going to be your methylxanthines. So your xanthine would be the ones that end with phylline, your theophylline, as well as aminophylline. These are actually weak bronchodilators. And therefore, it's not going to be a drug of choice for patients who are having respiratory difficulties. And the other thing is that you usually have to maintain a therapeutic blood level. So the therapeutic blood level of theophylline, which you need to remember, and it's a very common question in Nclex, is 10 to 20. And anytime it exceeds 20, it is now going to be a toxic level. So please remember that the therapeutic level for aminophylline is 10 to 20, and the toxic levels is anywhere above 20. All right. So xanthines are relatives of coffee and chocolate. So why is that important? Well, it's important because just like when you are overdosing with caffeine or chocolate, you're going to have different effects. And it's the same thing that would be the side effects of the use of your xanthine agents like aminophylline. So that would include what? Nervousness, tachycardia, increased respirations, restlessness, insomnia, tremors, cardiac arrhythmias. All those would be manifestations of aminophylline or xanthine toxicity. So just remember coffee and chocolate. I'm sure that you all have experienced drinking too much coffee. You haven't worked yet, but anyway, if you work night, you become a coffee addict. And in my life as a clinical nurse, I used to work only nighttime. I can't stand daytime because there's too much activity. So I always preferred nighttime. And I became an addict of coffee. And so I know what overdosing with coffee is. And I hope that you do too, because those are the signs of aminophylline toxicity. So for those of you who don't drink coffee or nor do you imbibe with chocolate, I'm just going to therefore look at write the side effects, and even is going to be the same symptom for aminophylline toxicity. Tremors, tachycardia, insomnia, restlessness, and what are some of the other things? Nausea. And others. Okay, so those are the most common ones. The reason I'm writing that down is because they might give you the signs and symptoms, and you are going to identify whether or not there's is going to be a potential that the patient is going to be toxic or not. Okay. All right. So another thing that that is important about xanthines, I need to tell you about this. Now, we all know, you all know, right, that patients who are COPD, they have been smokers, and even if they're short of breath, they continue to smoke. I mean, sometimes we don't understand that, but anyway, if you're addicted to it, I guess it's going to be very difficult. But there are some implications when a patient is taking these medications and he continues to smoke. And I will write that because this is very important. It's more likely than not that it will come out in the Nclex. So nicotine increases the metabolism of xanthines. So whenever a patient continues to smoke, what then is the implication? Should the dose of that medication be decreased, or should it be increased?
Increased.
Increase. Okay. So if patient, I'm going to write this again. If patient continues to smoke, medication dose and vice versa. If he stops smoking, obviously you're going to have to decrease the dose. All right. This is a very common Nclex question. 99% of the time it will appear, okay, in some sort of question or another, right? So the level of 10 to 20 is the therapeutic level, and toxic level is about 20. How do you know that a patient is toxic? Well, it might be manifested by the signs and symptoms of overdosing with caffeine. And then, of course, if they continue to smoke, because the metabolism of xanthines in the liver increases with nicotine, the dose must be increased in patients who continue to smoke. All right. This is 19. All right. Yes. Okay. So you got that. Stop sharing. Okay. Let's go to the next one. 22. All right. Yes, you're correct. The answer is A. The therapeutic range for aminophylline is 10 to 20. Okay, good. All right, there's also another classification of drugs which are useful in the management of patients with COPD, and that those are the PDE4 inhibitors. Don't confuse that with PDE5. PDE5 are those drugs that are used for the management of erectile dysfunction. PDE4 or phosphodiesterase 4 are a relatively new class of medications that have been marked to improve COPD. And the reason for that is because they have the ability to do two things, one of which is going to bronchodilate, and the other one is going to have an anti-inflammatory effects. So this is going to be a drug that is widely used. The drug name is roflumilast, and the trade name is Daliresp. This is going to be the oncoming drug that is going to be used for patients with COPD. Now, there is a black box warning, unfortunately, and this is the fact that these patients that are going to be on this drug have the potential to become depressed and actually might even become suicidal. So this is one important instruction that you're going to have to teach the patient and the family, to report any signs of depression. So black box warning. So I told you what black box warning is. The Food and Drug Administration requires that if there is any very important adverse effect of any drug, they must have a black box warning on the box itself, and there's going to be a risk of suicide. Okay. And the last class of medications are your steroids. So what are steroids? And the steroids that we use are going to be those that are inhaled. And the reason why we want inhaled steroids is because of the fact that the drug is going to be trapped locally, and therefore it will rarely produce systemic effects. Unlike when you take it by oral route, what's going to happen is the effect could spread all over. And that is the reason why we favor the use of inhaled steroids over the use of oral steroids, which is not usually a safe choice. So steroids are going to be identified by their suffix, and their suffix could be SONE or zone, like hydrocortisone, fluticasone, or Flovent. That's the most common. So zone is a common suffix of these drugs, and the other one is onide. And so budesonide is going to be one of them. So these Flovent and Pulmicort are very, very common steroid medications. And these medications have a benefit of exerting its anti-inflammatory effect. So if you have anti-inflammatory effects, you're going to decrease then the inflammation that causes the destruction of your alveolar wall. So usually these are not going to be used by themselves. They have to be in conjunction with either your beta agonists or your anti-muscarinic agents. So they usually are going to be in combination. Now, there are guidelines, or there are important things that we must obviously adhere to whenever we're giving these medications. So it's the same thing. What are the precautions? All right. When it is inhaled, there is a possibility of oral thrush from happening. And so what we need to do is whenever we're giving it, we need to teach the patient to spit and to rinse their mouth right after using it. Spit, rinse mouth. The reason is we want to avoid oral thrush from occurring. The other thing is that when you're giving a beta agonist and you're going to give a steroid, you always give the bronchodilator first, then wait 5 minutes, then the steroid follows. Okay? All right, so the use of oral steroids in the treatment of acute exacerbations is going to be recommended only on exacerbations, but they should not be prolonged because we'd rather use the inhaled route. So again, they all end in zone as well, like in prednisone or methylprednisolone. These are going to be the examples of your oral steroids. Okay, so let's take a look at the question over here. The answer is letter A. And so I am going to explain. Steroids are glucocorticoids, and they are the same, except they're synthetic, obviously, as our steroid hormones, which are released by the adrenal gland. So the complications when you give steroids, which is a glucocorticoid, are the following. So we need to be very cautious about these effects of glucocorticoids or steroids when used chronically. Number one is increase in blood sugar. Again, it's because it is a glucocorticoid, so it's sugar-based, and therefore it increases your blood sugar. It also increases the risk for the development of osteoporosis, and therefore the patient is going to have to be cautioned as far as bone fractures are concerned. The other effect is going to be lipodystrophy or fat redistribution. So they're going to have a buffalo hump, and they're going to have truncal obesity. They're also going to have an increase in cholesterol or hypercholesterolemia. So these drugs, these patients on these medications should be on statin. And cataract formation, as well as thin skin. There are other effects of glucocorticoids, but these are the most common as far as side effects are concerned. And of course, the last one is going to be weight gain. Mhm. Okay. Okay, so again, I wanted you to remember that all anticholinergic drugs are going to end with tropium. So the correct answers are letter B and letter E. Letter B and letter E. B and E. Okay, darifenacin or Enablex is actually a drug to treat overactive bladder. And your benztropine or cogentin and the akinetone or piperidine are both drugs that are useful for the management of patients with Parkinson's disease. They're anticholinergic, but they are used to treat the movement disorders associated with Parkinson's disease. Okay, so if there's one thing that you learned today, the answer to this is false. So let me explain in the next slide. All right, so the answer is false. Now, whenever we are taking care of patients with acute respiratory distress, the indications of oxygen is that you would give oxygen in order to maintain an O2 saturation of 85 to 90 or PaO2 of 50 to 60. So it doesn't matter if it's 1 liter that you give or 6 liters or 100%. The evidence now dictates that you must give enough oxygen to maintain a sufficient amounts to raise the PO2 to 50 to 60 or a O2 saturation of 85 to 90%. So please remove that from your mind now because you probably have been taught otherwise. But anyway, we would give oxygen however high it is, just so that we're going to maintain an O2 saturation of 85 to 90% or a PaO2 of 50 to 60. Okay. So what are the other things that patients would have to be managed with? Well, antitrypsin replacement, if they have that genetic abnormality that causes the emphysema, we encourage them to get these vaccines on an annual basis, the pneumococcal vaccine as well as the influenza. And of course, antibiotics are going to have to be given whenever the patient has signs of infection because of the fact that any infectious process in the lungs is going to precipitate them to have exacerbations and even having to buy a ventilator for that. So it is imperative to teach them to always report signs of infection. If the patient requires oxygen on a daily basis, evidence have shown that it would be better for them to maintain the oxygen therapy not on a PRN basis, but 15 to 19 hours per day. So oxygen should be given continuously between 15 to 19 hours a day for those who require oxygen long term. All right? So 15 to 19 hours per day. So the other interventions are patient teaching on how to manage their disease process, as well as airway clearance. And the way that we do airway clearance is, of course, bronchodilators. So we need to teach them about that. Direct or controlled breathing. Now, in as much as breathing is going to be much more difficult on expiration, it would be better for them to breathe like in a pursed lip breathing. And a lot of people still do not understand what pursed lip breathing is. It's when you control your exhalation, something like this. You're breathing or exhaling a little bit at a time by puckering or pursing your lips. This is to prevent the rapid deflation of the alveoli, which would make it more difficult for the patient to, again, inflate that alveoli. So diaphragmatic breathing as well as pursed lip breathing are very important. And of course, because they're intolerant to activities, we need to teach them to pace their activities as well as to use any aids that would facilitate their mobility and also exercise training, and of course, to prevent complications. Okay, so let's take a look at this one because I don't think you got it. Now, letter C, if you think, excuse me, take a look at letter C. Patient waits 15 seconds before using the inhaler a second time. Well, you remember it is going to be I'm sorry. Hold on. Let me just get a drink. One moment. Okay, if it's the same medication, where's my pen? In between breaths, it should be wait 1 minute, right? If it's a different medication, then we need to wait 5 minutes. Over here, he says, wait 15 seconds before using the inhaler a second time. So this means to say that it is very rapid. We should wait for 1 minute before using the inhaler a second time. The wait of 15 seconds indicates that the patient needs further teaching. Okay, so I see that you both answered letter A. Patient takes a deep breath while depressing the inhaler. So I have an inhaler here for demonstration. But when you depress the canister, you're supposed to take in a deep breath. So you do not need any further instruction because the patient is obviously doing it correctly. And you need to place the inhaler 2 fingers from the mouth like this. A lot of people do like this, which is inappropriate or not proper. They should use 2 fingers away from the mouth. Okay? And you should count up to 10 seconds after you had inhaled it. You count up to 10. You exhale slowly using a pursed lip breathing.
I have a question.
Yeah, go ahead.
So you take a deep breath when you're using a regular inhaler. How about when you're using a spacer?
Okay, so with a spacer, the purpose of a spacer is that you would have more time. And actually, we should all be using a spacer because coordination is very difficult for some people. So if this is the MDI and you have a spacer like this, why do you use a spacer? Okay, so when you use the MDI just like this, you really have to time it from the time you press it right here and you breathe in to be able to maximize all the drug. Okay, that's why you have to take in a deep breath and you hold it. With a spacer, you are now, the vapors or the medication is going to stay right over here. So, which means to say that you have a longer time to be able to take this in. Unlike in here, you really have to do it quickly. Over here, you can do it slowly. But then still again, you still have to take in a deep breath.
Right. I think that's what confused me because I have asthma myself.
Mm-hmm.
So I have a spacer. I've used it before.
Yeah.
And they told me to spray it and then inhale.
Right.
So that's why I got confused with the one directly. You have to do it as soon as you spray it. So that I think that's what confused me.
So remember, the difference is the MDI, the metered dose inhaler, and a spacer are 2 different things. Okay, so an MDI is just this device, and a spacer is the additional compartment for you to trap the gases. So that's a very good point. So remember, MDI and spacer, 2 different things. So spacers will provide you with better timing, actually. Okay. Next. Okay, so the question, did I? Okay, end the poll. All right. So the question over here is, the COPD patient may lose weight despite having adequate caloric intake. To maintain optimal weight, the RN should teach the client to continue the same caloric intake and increase the fat intake. Well, the problem with letter A is the client needs more calories. So the first part of the sentence is already incorrect, right? So let's eliminate letter A. Letter B, increase activity level to stimulate his appetite. Well, this is not feasible because, again, it will increase the oxygen demands and will result in further weight loss. So this also is going to be inappropriate. Increase the amount of complex carbohydrates and decrease the fat intake. This might be a good thing because you're increasing it. Over here, you decrease complex carbohydrate, okay, and increase calories, proteins, vitamins, and minerals. All right. So over here, letter C and letter D, what is the difference between the two? This included proteins, vitamins, and minerals, isn't it? So letter D is the best response. So you decrease complex carbohydrate, and the reason why you do that is because of the fact that you want to decrease acid production. And the more carbohydrates you have, the more acids you're going to produce. And therefore, what we need to do is to increase the calories, the proteins, the vitamins, and minerals. Right. So this one was very tricky because it says decrease complex carbohydrate, and you're thinking about the fact that he might need more carbohydrates. But again, if you are going to increase complex carbohydrates, you increase the production of acids. Okay. I apologize. You had a question that I didn't see.
Just to
Chantal.
explain B.
Yeah, which one was that?
The same, this one. Places in, what does that mean?
Okay. So when you are using this, okay, you're not going to put it into your mouth. You're supposed to have 2 finger breaths like this away from your mouth, and you open your mouth. You got it?
Oh, I thought it was always in your mouth.
Yeah. It's 2 fingers from the mouth is the proper way of using the MDI. I know you see people kissing it, right?
Yes, that's why I said to explain that.
Yeah, that's the wrong thing to do. And the reason for that is you contaminate actually the thing. It's a good thing if you wash it all the time, but people don't do that. And so having it away from your mouth actually will have you more, because you want to suck air in. And so if you have this thing, it's going to be very difficult. Whereas in here, you do this, it's going to be deeper when you take in a deep breath. Do you get it? If you put your fingers right here and you try to suck, it's not as strong as when you do this with your open mouth. And that's why it's always supposed to be 2 fingers away, contrary to what people usually do. They put it in their mouth, and therefore they cannot breathe deep enough. Okay, let's go to this one. Okay, so let's take a look at this one. A COPD patient is started on budesonide. So this is onide. So that is going to be a steroid. And fluticasone or Flovent, which is going to be also a steroid, 3 puffs TID. What patient statement indicates need for further teaching? I should use one inhaler, so like Pulmicort, then Flovent, and then Pulmicort, and then Flovent. Is that correct? If it's going to be the same medication, you're supposed to wait 1 minute in between, right? Okay. So this is problematic. Letter A. I must replace the inhalers before they run out. That's a good thing. I should rinse my mouth after administering the doses. That's a good thing. They should also spit out. I must use the inhalers even when my symptoms start to subside. That's also going to be a good thing, because you do not discontinue steroids right away. So letter A is going to be the one that requires further teaching.
Good
Okay?
question.
Yeah.
Why are they? Okay, I guess I kind of figured it out. I don't know. I'm just trying to figure out why they're on 2 corticosteroids.
Yeah, because the other one is fast-acting steroid or short-acting, and the other one is long-acting steroid. Yeah.
Maybe I'm thinking too deeply.
Yeah. So the fluticasone is going to be the budesonide actually is going to be fast-acting or short-acting, and the fluticasone is longer-acting. Yeah. Mm-hmm. Okay, so let's take a look at the correct answer. Here is letter D. Again, I wanted to emphasize it's a frequent question from the Nclex. The reason is nicotine increases the metabolism of theophylline, so the dosage may need to be increased to produce a therapeutic effect.
This one is tricky.
It is tricky. Okay. So
The vocab.
yeah, I mean, it's confusing as far as the wording is concerned, right? So a patient is admitted with exacerbation of COPD. The nurse teaches pursed lip breathing to help keep airways open by, okay. So when we expire forcefully, we have an increase in intrathoracic pressure, right? So that's forced expiration. But when we have controlled exhalation, like in pursed lip breathing, we're maintaining actually the intrapulmonary pressures in the airways as the person exhales slowly. So this decreases the intrathoracic pressure. So the correct answer here is letter B, decreasing the transpulmonary pressures. The reason is, again, you are breathing control. So when you do this, you increase intrathoracic pressure because you deflated it right away. In pursed lip breathing, you are deflating it very, very slowly, and therefore you decrease intrathoracic pressure. I don't like this question myself, but anyway.
The answer is D.
B, as in boy. You decrease intrathoracic pressure when you do pursed lip breathing. So it's the opposite of D. Okay, so let's now go to the case study. And this is a 74-year-old female admitted to the emergency room with increasing dyspnea, productive cough, and fatigue. The client arrives in the emergency department with increasing shortness of breath over the past week, strong productive cough with green-tinged sputum, and fatigue. The client has a history of chronic obstructive pulmonary disease, emphysema, has been using the relief inhaler at home with no relief of symptoms. Client lives independently and states they smoke, oh boy, approximately 1 pack really of cigarettes per day, ambulatory alert and oriented, has coarse crackles in bilateral lung fields with a barrel chest appearance, using accessory muscles, expiratory wheeze on auscultation. Client states they have less room to take a deep breath, clubbing noted in all digits bilaterally. So when you're given the first question, it is asking you to make a diagnosis, okay? So you're now gathering all this information, and what are some of the important words over here? The patient is a smoker. She has a green-tinged sputum. She also has coarse crackles and the barrel chest. So what is coming to your mind now? What is your diagnosis?
COPD.
COPD. Very good. Okay. So the temperature 99, pulse 104, respiratory 27, blood pressure 157/86, 91% on room air. There's no pain. So the nurse reviews the client's initial assessment. Which priority findings would require immediate follow-up? So we're looking for findings that would require you to follow up immediately. Okay. So I think that I need to emphasize this with you all. It says, which priority findings? Priority, meaning to say you have to address those right away. Okay? So these are the most important things. All right. If a patient is breathing and they're using accessory muscles, is that a dangerous thing? It requires immediate intervention, isn't it? So we should have put this as a yes, right? The other one, clubbing. This is a chronic finding. Do you need to address that right away? I mean, will he die or will she die because she has digital clubbing? The answer is no. So we're not going to select that. Crackles. What does it mean when you have crackles in the lungs? That means to say that you have fluid collecting in the lungs, and this could worsen oxygenation, for example, or even trap carbon dioxide. So I think that we should chews coarse crackles. The fact that she is a smoker is important, but do you need to do anything about it right away? And the answer is no, you don't need to do it right away, because you remember it says priority. We're looking for the most important things that you need to address. All right, green tinge sputum. This is an abnormal finding. Whether we like it or not, a green tinge sputum, in addition to being gross, is the manifestation that an infection is fostering in the patient. And so this one is going to be something that we have to address. The fact that she does not comply with her medications is not an immediate thing, because you remember, when patients are in distress, you cannot teach them because they're not going to pay attention to you. So you're going to do that later on, but it's not a priority. And the temperature of 99 is not dangerous to have a temperature of 99, but tachypnea is going to be a manifestation of something serious going on. So I think these 4 things are the most important thing at the moment. Okay?
Can you give me like a
Sure.
mental picture of using the accessory muscle?
Yeah. You know, if you take a look at me,
Shoulders.
and your neck becomes very, very stiff because it's an effort to exhale or to breathe. That is use of an accessory muscles.
Okay, so you can see when the patient.
Oh, you can. You certainly can. You could see their shoulders going up and their neck tightening up like this in order to force the air out. That is what's called accessory muscle use. And there's also intercostal breathing. You could see, actually, intercostal means to say in between the ribs. You could see, if the patient does not have clothes on, you could see the ribs really tightening up to try to eliminate the air. Okay, that's intercostal breathing, which is another way of enhancing respiration. So it's another accessory muscle use.
Okay, thank you.
Sure, you're welcome. Okay, so let's go to question number 2. So everything is the same, right? There's nothing that has changed right over here. It's still the same, but there is a question. And for each client finding, right here, click to indicate if the finding is consistent with asthma, chronic obstructive pulmonary disease, pneumonia, or pulmonary embolism. So it's asking us, is dyspnea a symptom of asthma only, or COPD, or pneumonia, or pulmonary emboli? So we're supposed to check each one of them. All right. So if a patient has asthma, will they have dyspnea? I don't have a poll on this one, so we have to do it this way. Yes or no?
Yes.
Yes. Okay. How about in COPD? Yes, we would. Pneumonia? Yes, we would. And pulmonary emboli, all these things could cause dyspnea. All right, how about a productive cough? Asthma, yes, you could have a productive cough. COPD, you could have a productive cough. Pneumonia, you could have a productive cough. Pulmonary emboli, no, you do not have a productive cough. In pulmonary emboli, you remember they have chest pain. It's almost like similar to the signs and symptoms of an MI. And if they ever have another symptom, it will be hemoptysis. They will cough up blood. So this is not going to be a symptom that is associated with pulmonary emboli. Barrel chest. Do you have barrel chest in asthma? No.
No.
But you would have it in COPD. You will not have it in pneumonia or in pulmonary emboli. Okay. In digital clubbing, you remember why we have clubbing? Oh, I didn't mention that. But clubbing of the fingers is because of chronic oxygen desaturation. So it usually accompanies patients who are going to have chronic lung diseases. Okay, so it usually is not a finding in asthma, but it certainly is going to be a finding in COPD.
It isn't a sign of like person who smokes a lot or no?
If they have COPD, yes. Yeah. Yeah. The reason why smokers usually have the clubbing of the fingers is because of the fact that they have now developed emphysema or bronchitis. Yeah. Okay. How about wheezing? Do you have wheezing in asthma?
Yes.
Yes. And COPD?
Yes.
Yes, you do. And also pneumonia. But you will not have any wheezing at all in pulmonary emboli. So remember, pulmonary emboli, the symptoms mimic that of a myocardial infarction. Okay? So it rarely is going to be, what do you call that, a cough or something like that. If anything else, it's going to be hemoptysis or coughing out blood. All right. So let's go to this one now. It's the same situation, but we're now asked to determine what is happening to this patient. So I have a poll over here. We can do that. Oh, I repeated that. It should have been pneumonia. Okay. All right. So yes, it's COPD exacerbation. The choices that I put on the poll was in error. Okay. So let's go to question number 4. So it's still the same thing. And now over here we are asked, the nurse anticipates the provider's orders and considers possible nursing interventions. Select the orders from each of the categories the nurse should include in the plan of care at this time. Each category may have more than one answer. So I have a poll on that one. Okay, so let's take a look at what we should do. All right. So the nurse anticipates the provider's orders, and would we want to give high flow oxygen right away? The O2 saturation is 91%. Do you want to go nuclear right away? High flow oxygen face mask?
No.
No, okay, because we might have the patient quit breathing. Place the client in a high power's position, definitely, right? And if there is any other choice, that is what's known as a tripod position. That's the one that assists patients in respiratory distress to breathe better. Tripod position is putting your hands, both your hands, onto your knees and leaning forward. And this will help you breathe when you're having difficulty in breathing. This is what is known as a tripod position. So if that option is ever there, always select it because it's the same as putting the patient in a high powers position. Okay. Now, encourage the use of incentive spirometer. Let's go back to this one. I'm not sure. ondansetron. This is going to be a medication that is going to be for nausea, and therefore this is not going to help us at all, right? So how about ipratropium? You remember tropium? That is a bronchodilator, right? It's an anticholinergic. And prednisolone, this is a steroid, so that would be okay. Now, in as much as it's select all that apply, if you are not sure about this, obviously you're not going to choose it. But
Isn't
there's
this
a reason.
barometer more for pneumonia? This barometer.
This parameter is more on post-op
prevent?
patients, to prevent pneumonia. You're correct, right? But it might not be a bad idea. And the reason is, if you are having a patient with, what do you call that? A patient with COPD, and you are trying to encourage them to use a spirometer, the spirometer might assist in maximizing the lung expansion and therefore the ventilatory efforts of the patient. So it might be okay. So if I am taking the exam, I'll only choose these three because this is questionable, but actually this could be a correct response. Okay, so remember what I was advising you when it's select all that apply. Only choose the ones that you are sure of, because it's right minus wrong. And that's the reason why I say be very, very stingy in answering a lot of choices on select all that apply. Okay, let's go to the next question. And so we now have new data, and that data is at 10:15, the client has increasing dyspnea, prefers to be sitting up in the chair, requesting rescue inhaler. The provider has been notified. Ipratropium bromide and albuterol, the nebulizer treatment, were started. And so we have changes over here. The temperature is still the same. The pulse is a little bit higher. The respiratory rate is 30, and the blood pressure is minimally higher than 10 o'clock. And there's a little bit of change in the pulse oximeter, not that significant. And now we were given orders for ipratropium and albuterol, and acetaminophen, methylprednisolone, amoxicillin, and albuterol. So ipratropium is an anticholinergic, right? Or an antimuscarinic bronchodilator. Acetaminophen or Tylenol, we know that's analgesic as well as antipyretic. Methylprednisolone is a steroid. Amoxicillin clavulanate is an antibiotic. And albuterol is going to be a beta agonist. So it's a bronchodilator as well. All right. The ipratropium bromide albuterol treatment is given. Which medication should be given next? Oh, tricky.
Very.
The reason I'm saying it's tricky is if you take a look at here, over here, it says
Oh, it has all three names.
the ipratropium bromide and albuterol were already started. Okay. So you all answered correctly. I'm so proud of you, because what's going to be next? is the steroid, right? It is going to be bronchodilator first, then followed by steroid. Okay? And so whenever we're treating these patients with bronchodilators, I want you to remember AIM. And it stands for albuterol, ipratropium, and methylprednisolone. As a nurse practitioner, I was taught that I always have to do AIM in sequence. A first, albuterol, ipratropium, and then methylprednisolone in that order. Okay, so beta agonist, anticholinergic, then steroid. Okay, you did good in that one. All right, so let's go to the next now. We have additional information, and so let's read what the additional information is. At 10:45, the administration of ipratropium and albuterol and IV prednisolone were complete. Assisted client onto the bed and placed in high Fowler's position. Breath sounds noted to have coarse crackles in bilateral upper and lower lung fields. Oh, this is bad because it's upper and lower, okay? No expiratory wheezing. Client continues to state they feel severe shortness of breath. Okay, so let's see, 10 o'clock, 10:15. This should be 10:45, not 10:15. Okay. So 117. Oh, the respirations is worse. And the blood pressure is worse. And the O2 saturation is worse. Okay, so what are they asking us next? So, the nurse administered the ordered medications and assesses the client at 10:45. For each client finding, click to specify if they are better or improved, or declined or is unchanged. Okay, so let's answer this. Is the respiratory rate worse, improved, declined, or unchanged? It's worse, right?
Decline.
Yeah, so they use the word decline, so that means to say it's worse.
Yes.
So we'll have to say this is declined. All right. How about the heart rate? The heart rate was... We'll have to go back to the other slide to see the heart rate. The heart rate was 104, 108, 117. So 117, the pulse. So this would be worse, right? And then pulse oximetry, it was 90
Worse.
before. Oh, it's worse. Blood pressure, worse.
Getting worse.
Wheezing, oh, it was worse because I think
it says
no,
no
wait.
expiratory.
It's getting better.
Better, yeah.
It's better. No wheezing. Okay. And breath sounds, you remember crackles
Breath
in
sound.
bilateral and lower lung fields. So it's both upper and lower lung
So
fields.
it's worse.
It is worse, definitely. And the temperature, it hasn't changed. So I guess this is unchanged. All right, so that ends our case study. And so I'm going to miss you all, but anyway, it will be our last day tomorrow. And I wish you all luck. So I hope to see you tomorrow for our last discussion. Okay?
Thank you.
What subject are we
Thank
doing
you.
tomorrow?
Hold on one moment. Let me see. it's our final day of grading papers, and so my mind is all in different places, so I don't even remember what I'm going to do. It's thyroid tomorrow.
Oh, good.
Yeah.
Great.
Which
All
one?
right. Thyroid.
Thyroid.
Hyper and
I did that so many
hypothyroidism.
times. Oh my God.
I know I was struggling with it all today.
Oh yeah, really? Okay, so the choices are, I could change it if we want but we have UTI, we have GERD, we have pharmacology, psychiatry, psychiatric medications. So, but the last time, what I did was, because thyroid endocrine disorders are also very high yield in Nclex, so I thought that I might tackle thyroid, unless you want something else.
That's fine for me because I need to review that as well.
Okay, good. We'll do it. All right. So you all take care. Have a good evening, and I'll see you tomorrow. Same
Okay,
time.
thank you.
Yes.
Thank you.
Okay. Bye.
Bye.